Uh-oh. Just did something funny. There's other people coming in now. All right, hang on 1 minute. All right, so somehow in my screen sharing. Anyway, can you hear me?
Yep, we can hear you.
Okay, so I'll do the introduction. It's my pleasure to introduce Dr. Chevez-Barrios. She assumed her current position at Houston Methodist Hospital in 2004, where she became professor of pathology and ophthalmology at Weill Cornell Medical College. She has current appointments of adjunct professor in the Department of Pathology at the University of Texas MD Anderson Cancer Center and Department of Ophthalmology at Baylor College of Medicine. She has published more than 100 peer-reviewed articles, authored several book chapters, is editor of peer-reviewed journals, and participated in lectures, meetings, and visiting professor lectures nationally and internationally in the fields of ophthalmic pathology and cytopathology and retinoblastoma. She is co-founder and co-director of the Retinoblastoma Center of Houston since 2009. Preclinical models of ocular disease have been her research interest, and recently she's working on a preclinical model of retinoblastoma and the study of microgravity effects in the eye, mostly on the NASA International Space Station. She enjoys teaching and the presence of students, residents, and fellows of different programs and levels of training with whom she spends most of her day sharing experiences with pathology cases and research. I will now turn it over to Dr. Chevez-Barrios. Okay, so Dr. Chevez-Barrios, do you need to screen share now?
Yes.
There we go, very good.
Can
And,
you hear me?
Yes, we can.
Yep, perfect.
Okay. Perfect. So thank you very much. Good morning, everyone. And it's a pleasure for me to be here in this American Association of Neuropathologists ground rounds. So I will be talking mainly about uveal melanoma, retinoblastoma, and cataracts. I have nothing relevant for this talk to disclose, only my grant support. Please don't take pictures or share this because some of these pictures have copyrights or are not published yet. So we already went through these objectives. And the outline is we are going to start with the uveal melanoma, specifically histopathology diagnosis, evaluation, and prognosis. Retinoblastoma, we are going to talk about how to handle an eye with retinoblastoma, evaluation, and prognosis. And cataracts, very quickly, just classification and key features in histopathologic findings. Then conclusions and some questions and answers. So uveal melanoma is the most common primary intraocular tumor in adults. As you can see here, the incidence is more often seen in mid-adults and older adults. Children can have it, but it's not the common. The melanomas start from the dendritic melanocytes in the uveal tract. The uveal tract is composed by the choroid, the ciliary body, and the iris. The iris, as you recall, is the layer that gives the color of the eye, and it's in the front. And then behind is the lens. And the ciliary body has other functions like moving the lens, etc. The most common location would be the choroidal melanoma. So they expand the choroid in 90% of the cases. 6% in the ciliary body and 4% in the iris arise in there. The metastatic rate is 50%. So of all the patients with uveal melanoma, 50% will have metastasis, and the metastasis will go to the liver in 80% of these cases. 90% of patients prior to death have it in the liver. And a third of this metastatic disease is only in the liver. there is no survival difference in patients that are treated with a plaque radiation versus the ones that are enucleated. And this came up in a COM study some years ago. So one specific thing about the eye is that ophthalmologists have become really good at diagnosing this by imaging and other means, and they don't need biopsy to treat these patients. They only need the biopsy because now the molecular prognostication is so good that they need tissue for this molecular prognostication. So clinically, they will decide if it is a benign nevus versus a melanoma. When they decide it's a melanoma, they have the option of treating with a plaque versus enucleation. Usually enucleation is left for larger tumors with extraocular extension or because the patient wants the eye out. But if they have to do the radiation plaque, they take a FNA biopsy and then send it for molecular testing. And of course, in the same way, you can confirm diagnosis. Of course, metastatic screening of the liver is always in this triaging of the patient. Then what are the prognostic factors? So one of them is location, because it's related to the symptoms these patients will have. So the early you can detect it, the better the prognosis. So ciliary body has the worst prognosis because it's hidden behind the iris. It has to grow to a certain extent, like in this case, to be seen through the lens. The iris has the best prognosis, is diagnosed about 10 years earlier than the others, and is very non-aggressive because you can see it immediately as it appears. Size is one of the worst, one of the more solid prognostication in histopathology prognostic factors. And if you have a tumor more than 10.5 millimeters at the base, like you see it here, or and 5.5, more than 5.5 in thickness, that is a very bad prognosis for metastases. The other strong prognostication for in histopathology is the cell type. So you have this 3 calendar modified classification based on cellularity. So a spindle is composed of these 2 types. A is without nucleoli, B with nucleoli, and then the epithelioid one with the round epithelioid cells by itself. If you have more than 30% of the cellularity, you can call it epithelial melanoma. If it is less than that, then it's a mixed melanoma, spindle and epithelioid. The other strong prognostication is vasculogenic mimicry, when the tumors are, the tumor cells are actually forming these channels that look like vessels and that actually carry the cells out and connect to the vascularity, the real vessels, and produce the metastases. So the more and more complex you have, the worse the prognosis for metastases. Vortex vein thrombosis, of course, is not good because the vortex veins are the ones that drain the choroid out into the systemic circulation. Infiltrating plasma cells specifically is not a good prognosis because that means that the tumor, which is in a immune privileged site, has already reached the immune system in the circulation, and now the plasma cells are recognizing and have antibodies against this. When you are faced with a probable metastatic lesion from the uveal melanoma, or you have a uveal melanoma that is a melanotic and you have doubts, is this melanoma versus not? The best way to go is using HMB45 and melan-A, because S100, although it can stain everything, but specifically the uveal melanoma may be negative in 60 to 80% of the cases. So forget about the S100, go for the HMB45 or melan-A. And for, just to assure that we have a melanoma, not a nevus, we always use the combination of HMB45 and Ki67, where you can see the proliferation in the tumor. So how do we, so all of these features are okay in the nucleation, but now we do more and more this cytology FNAs. And so this is a tumor that it looks, see, it's a small, this is the optic nerve from inside. So now with a very thin needle, it's usually 27, 29 gauge, they will take this little biopsy. So in our practice, we are there at the site of the surgeon and do the evaluation on site. And so we are assured that the molecular vial has the tumor cells. And because this is very important, because these gene expression profile intestines are not going to identify malignancy versus benign tumor. So blood and normal tissues will give you a class 1 low grade for high risk for metastasis, or the malignancies of other type, including mesothelioma, can give you BAP1 mutation. So you need confirmation in cytology that this is actually melanoma. And you may get 2 or 3 cells like this, but then you say, okay, this is melanoma. You have your epithelioid or your spindle ones, and then you can do cell block and confirm with immunos. The main mutations that give the prognosis are here. So all of the initiating melanocytic mutation is the GNAQ and 11, because these are the ones that are going to transform the dormant melanocyte into the neoplastic melanocyte. But all of this, the benign, the good prognosis and the bad prognosis tumors will have this mutation. From there, then you have the specifically BAC1 and monosomic chromosome 3 are the ones that will give you the class 2 melanoma, which has the highest risk for metastasis at 5 years, so about 72%. If you have a class 1, which goes this way, it's 2% metastatic risk. So it's very low, it's like an EVIS. Then 1B is in between. And the difference between 1A and 1B is all of these mutations, extra mutations in here, and the PRAME. If PRAME is positive or not, then we'll give you more. If it's positive, it's going to be sooner than that. Now, very important for us pathologists is forget about BRAF, nothing to do with melanoma of the uvea. This is different mechanisms, different pathways, nothing to do with the skin melanomas. Okay, so that is the importance of having that sampling and confirming diagnosis to interpret actual molecular testing. Retinoblastoma is the other tumor that we are going to visit today, and is the most common primary malignant ocular tumor of childhood. And in fact, worldwide is the most common intraocular malignant tumor. In the United States, it's about 350 new patients a year, usually diagnosed under 4 years of age. 98% of the cases are associated with a mutation in the RB1 gene and can be inherited in about 40% of the cases with bilateral tumors. Rare tumors, less than 2%, have an intact RB1, so they are not mutated RB1 gene, but have amplified MYC-N. The most common presentation is the leukocoria or the white pupil, and the tumor arises from the retina and invades either inside or subretinally, and is formed by retinoblasts. So as I said, worldwide, it's more than the United States, about 8,000 cases a year. And the bad part of this is about 3,000 patients or more die of retinoblastoma annually in the world. And most deaths occur in continents such as Africa, with a death rate of about 70%, or Asia with 42%. And the problem is these presentations. They present with us when they have already late diagnosis, invasive malignancy, micrometastasis. And it's very difficult to treat. So what happens usually with the RB1 mutated tumors? This is your normal phenotype. You have your intact 2 RB alleles with the production of the protein. You have a hit, a genetic hit, and then you have a loss of 1 allele, but you still have production, normal phenotype. Second hit, it could be epigenetic, and then more mutations, and then you can have then the tumor. You have now the phenotype of the tumor with the absence of the RB1 mutation. Now, a caveat here, about 98%, 90% of the tumors will have this negativity, but some of them will produce a dysfunctional protein. And they are mutated, but they still produce a dysfunctional protein. So your immuno will detect the RB1 protein, although it's not functional. So retinoblastoma is a tumor suppressant gene, and it's involved with anti-apoptosis, differentiation, negative regulation of the cell cycle, and DNA damage repair. There are many mutations that have been identified, some of them epigenetic, to produce retinoblastoma. Now, a parenthesis, hereditary retinoblastoma syndrome is a hereditary cancer predisposition syndrome. Is linked to the constitutional heterogeneous pathogenic RB1 variant. So it is germline mutated, and produces development of retinoblastoma plus extraocular primary malignancies. So you have a bilateral retinoblastoma, and you may have another primary, like intracranial tumor, the trilateral retinoblastoma, so-called. Could be pineal or supracellular. But also they can have second primary malignancies, and they are treated, the type of tumor is treated dependent. So the risk of developing the second malignancies for this syndrome is 0.5 to 1% per year of life. Osteosarcomas are seen in the first and second decades of life. Soft tissue sarcomas 10 to 50 years after retinoblastoma diagnosis, and carcinomas and melanomas after the second decade of life. So this is more or less what to expect. And that's why it's very important to identify the bilateral tumors, the germline mutated, because you have to follow these patients for life. So classifications, you can do the genetic, and this is what is in the AJCC now. The sporadic, which you don't have any mutations. Hereditary, you have the bilateral, you have the syndrome. The unknown X, you will put, you don't know, you don't have tissue to do the mutational studies, and then the MIC and amplified. You need more than 28 copies to have this amplification diagnosis. And then you have the classification histopathology, the type of growth in the eye, the production of vitreous seeds. You see the mitosis, the apoptosis, and the degree of anaplasia, the typical presentation of the rosettes, and then the MIC, the RB1 positive, MIC and amplified, that is very different from your regular retinoblastoma, does not form rosettes, and it has this round nucleus with prominent nucleoli. So you can kind of identify these cases by the histopathology. Now, why is it important to get genetic confirmation of sporadic versus germline? Because you have all of these family members at risk of being followed, EUAs and exams under anesthesia and everything. This is a table we published. If you don't have the genetic studies, all of these are the estimated risks of developing retinoblastoma in a family member with or without germline mutations. But the best way is to have tissue and blood, and then follow only the patients that have the risk. How to handle the eye with retinoblastoma. So the first thing you have to do when you receive an eye, especially when it's fresh, is to take the optic nerve margin, because you don't want to contaminate your margin with the tissue. Then we do a touch imprint, but you don't need to do that of the cut section to estimate if there's tumor at that end. This then transilluminate the eye so that you can decide where are you going to cut the eye. And then the grossing, obtain the central section of the eye, then the calottes, which are the caps, and then the optic nerve. You submit the whole eye for histologic examination, several sections. And then the point of the report and prognosis is to confirm diagnosis and evaluate the high-risk features. So this is what it's in this publication. You can read it, but this is what I mean about the PO section is the central section, not cutting through the optic nerve. I have seen in consultation several times that the people cut through the optic nerve, thinking that you are going to see better. No, because you know this, the histotechnologist is going to cut and level the block and may get rid of, during this cutting, of your diagnostic invasiveness of the tumor. So you put the optic nerve intact. Your sections are below and over the optic nerve, and then the histotech is the one that is going to reach the level of the center of the optic nerve. You is recommended, highly recommended, that you can only diagnose the level of optic nerve invasion if you have the center of your section, meaning the vessels coming through, because this is a thinner area where the tumor likes to go through the optic nerve, and then evaluate the level of invasion. So you do several sections of the PO section, pupil optic nerve section, and then the calottes, we further cut it like that to evaluate choroid. So in 4 cassettes, you have the entire eye. Growth pattern, the endophytic grows from the optic nerve. This is growth patterns from the retina into the vitreous. This can cause tumor invasion into the optic nerve by tumor seeding. The exophytic grows from the retina to the choroid under the retina and causes choroidal invasion, or the mix, which is the most common one, can have both high-risk features. Anterior diffuse is seen in older patients, doesn't produce any mass. It just has a little mass at the periphery, and it's an invasive behind the iris. This is behind the iris, looking from the optic nerve down, and it grows into the anterior chamber. It mimics uveitis. It's very difficult to diagnose for the clinician. And the necrotic, extensively necrotic, it has to have more than 90% necrosis. This is a total infarction of the eye and the tumor, and they usually have other high-risk features. It arises histopathologically. It arises from the nuclear layers of the retina and invades other areas, has geographic areas of necrosis because rapidly outgrows its vascularity. And then it has apoptosis, necrosis, mitosis. And you can have the isopartin phenomenon because of the necrotic cells. In the type of tumor, you can have poorly differentiated, no rosette formation, or the Flexner-Winterstein, and the typical ones that have this empty space in the center, or the ones, the homerites that are seen more in other tumors that have the neuropil filling the hole in here, and the florets, which are the most differentiated one. If you only have these florets, the tumor is called retinocytoma, and it looks like little bouquet of flowers. So his vitreous seeding, it's coming from little pieces of the tumor and floats in the vitreous, very difficult to treat unless you do intravitreal chemotherapy. And the problem is that they can seed other areas and produce new tumors. Histopathologic features that needed to be addressed in your report. Extraocular extension is the worst for the patient because the tumor, if it is confined to the eye, it has 98% success rate of cure. But if it is outside, it jumps to less than 20%. So optic nerve invasion, the level of invasion, post-laminar cribrosa and surgical margin obviously are the worst. choroidal invasion, you have to divide it massive versus focal and others. So here is what I mean about the lamina cribrosa. You have the lamina cribrosa here, which is the extension of the sclera. And then anything beyond the lamina cribrosa is postlaminar. You measure it from the Brooks membrane down. This number is important. We had found that 1.4 or more is higher risk. And you can see how it goes up, the possibilities of metastasis. A choroidal invasion, you can say massive, but you have to have a number. So more than 3 millimeters, equal or more of 3 millimeters of invasion, and reaching the sclera is massive. And if you have plony as well, postlaminar optic nerve invasion, this is the worst combination for prognosis of recurrence in the CNS. Focal choroidal invasion is less than 3 millimeters. It does not reach the sclera, and this is not a high-risk feature. So here it is, your massive choroidal. If you have any doubts if this is retinoblastoma, use synaptophysin. Is a very good marker for retinoblastoma. Neovascularization of the anterior chamber, invasion of the iris. We don't know the value of this. There are no prospective studies on this. Necrotic retinoblastoma has higher risk of high-risk features. So case one is a girl with unilateral retinoblastoma. You see here the tumor arising from the retina, filling the vitreous. It has some differentiation. It has rosettes, both types. It has vitreous seeds at the base of the vitreous, sub-RPE invasion, but not into the choriocapillaris. This is not choroidal invasion. This is still not in the choroid. So no invasion into the choroid. The optic nerve at the level of the vessels is, and all levels is negative. So your report has to say all of this, the degree of necrosis, just because of the extensively necrotic carries worse prognosis. And your genetics in this tumor is negative. It doesn't have the germline mutation. So your staging at the end is PT1, no invasion. And there's H0, the grade is 1, and the because this is very well differentiated, and the stage is 1. So in the new, in the HHCC 7 edition, you have the only thing that has the worst value is PT4, because it's the only one that will change the final staging. And here you know that this is the only tumor and the first tumor that now has the hereditary trait in there because it has prognostic value. This is the second case. This patient is bilateral. You can see the two tumors in the eye, in the two eyes. And when you see the enucleated after chemotherapy, they did chemo and then enucleation, you can see the massive postlaminar optic nerve invasion. It reaches the meninges, although it doesn't go into the subarachnoid space, but it is in the meninges. RB, of course, is found in tumor and blood. So this one has a very high risk for intracranial extension. The patient had, of course, a stage post-chemo 2, and follow-up after 5 months of adjuvant chemotherapy. The patient presents with seizures, and you can see here in the MRI the recurrence in the orbit and into the meninges in here. She went through a lot of chemotherapy, bone marrow transplantation, radiation, and had initial response. This melted down, but then she had recurrence and died of disease. Why is that? This is the worst prognosis when it's in the CNS. There's a very low success rate of about 2%. What happens when the tumor invades the optic nerve? It can go through the solid nerve fibers into the brain directly, or it can go through the CSF, through the meninges into the CSF in the brain. If you have it in the choroid, it is vascular systemic metastasis, most of them into the bone marrow. If it is anterior and the tumor invades extraocularly, it can reach the lymphatics. The only place that we have lymphatics is in the conjunctiva, so it can go into the lymphatics. In this recent paper of a prospective study, more than 300 patients, we found that the combination of massive choroidal invasion peripapillary with plony has the worst prognosis because you have all these piercing vessels. So the tumors can go around the vessels and then micrometastasis occurs into the CSF and can recur later on. So now these patients are treated with higher dose adjuvant chemotherapy. Cataracts. So to understand the lens, you have to go back to the development of the eye. The eye develops through forming this optic cup with a neural crest, neuroepithelium here that is going to form the retina and the retinal pigment epithelium, and the ectoderm that comes from the lens placard anteriorly. So this one is going to form the surface epithelium of the cornea, but also the lens. So it invaginates into the cup and at one point separates from the surface and forms this little vesicle. It is lined, as you see here, by the epithelium of the ectoderm all around in this cavity. And this epithelium starts to migrate anteriorly and fills the whole thing, leaving behind only the cytoplasm called the fibers now. And it forms the nucleus with the original fibers. And as it grows, it forms more fibers, but the epithelium is only left anteriorly and at the equator. In the equator, the epithelium continues to replicate. Not epithelium in the back, nothing in the center in a normal development. So here you can see how the cells migrate anteriorly. So in a developed eye, you can see the lens is behind the iris. It's held by these zonules. So they are attached to the ciliary body, pars plana, and they go here. And the muscle of the ciliary body is the one that is going to move the eye for refractive purposes. And it's a clear refractive media. So it has to be totally transparent, no vessels, and is flexible. Here you see it in this enucleated eye. When you fix it, it's becoming yellow. So it's normal, but it's translucent when it doesn't have a cataract. This is from the view from the back. And you can see how it's held here by the zonules are very difficult to see. And here you see it in the histology. So from this BCSC book, you can see the different parts of the lens. The nucleus is the central portion, the older part, the cortex around, and the posterior lens capsule. The capsule is just the basement membrane that surrounds the whole thing, and the equator of the lens where the nucleus can be replicating here still. In the anterior portion, you have the anterior capsule and the epithelium, as you can see it here. The capsule in the posterior part is very thin. So here's, you can see it in this enucleated eye. And you can see here how it's held by, so maybe you can distinguish here the fibers. They are very thin. Basement, here you can see it better. Basement membrane that holds the lens. And see, you can see the translucency of it. So cataracts are increasing in incidence worldwide, and right now is the leading cause of visual impairment and blindness. The risk for developing cataracts is a strong association with older age. That's the most common one. Tobacco use, diabetic patients, and UV light exposure. Other associations are hypertension, corticosteroid, prolonged use of corticosteroids, genetic predisposition, trauma, high myopia, and female gender. Cataract surgery is associated to economic availability of healthcare, of course. So, like everything in healthcare, it prevents morbidity and improves quality of life, of course, these cataract surgeries. You can divide in many ways the classification of cataracts, but, pediatric and adult cataracts. The pediatrics, of course, usually associated with congenital or other things, and it could be unilateral in both, can be unilateral or bilateral. In bilateral, of course, in children is more hereditary, genetic, metabolic, or infectious like torch, ocular abnormalities and toxicities. And in unilateral, always think about trauma in children, and then you have to rule out child abuse. And sometimes they are bilateral, but one is more prominent than the other one, radiation. Also in adults, of course, the most common age-related, toxicity, genetic predisposition, and trauma. So this is one of the pediatric cataracts, but also kind of malformation. This is persistence of the tunica vasculosa lentis and the cataract and malformation of the lens. In Coats disease, you have this cataractus, very small lens, but also with cataract. So how do you see these cataracts in microscopic examination? So this is a total cataract, and the total means that it has subcapsular, cortical, and nuclear cataracts. So in this case, you have a nuclear cataract, a cortical cataract, a subcapsular here. These globules, more globules, are in the cortex, and they are like these globules, like balls. In this case, it was ruptured, the capsule here, by this tumor. This is secondary to a tumor, and then you have here the some macrophages. You can have calcification in these areas. This is another cataract in a patient with meduloepithelioma, and you can see the nuclear cataract. You see it white instead of your yellow that you are used to. And the specific finding in anterior subcapsular is that you have this duplication of the lens capsule with metaplasia of these cells to a more myoepithelial or fibroepithelial cells. And they form these plaques. Clinically, it looks like white plaques in there. And then you have your cortical and nuclear cataracts. The bladder cells, you see it in posterior subcapsular. There are these Whittle cells also called. They have this, elongated, large with nucleus elongation, and then the cortical changes. For the nuclear is better seen in gross description, so they change the color. It could be yellow to brunescent, and they can have very dark brown color, and this is because accumulation of urochrome. And usually histologically, you just see this homogeneous eosinophilic fibers. You can have also crystals in there. Sometimes you can see them, and calcification. Secondary cataracts, you can have secondary to inflammation, to tumor, like in this case, this is a retinoblastoma after treatment and everything. So you can see the nuclear cataract, the subcapsular and cataract. This patient also underwent radiation, so you can have also that, and post-traumatic. So what do they do when they operate on? So they go through nowadays they go through a clear cornea so that you don't have any scars here, and then they reach the anterior capsule of the lens, and they take out the anterior capsule. so that they can put the this machine that extracts, emulsifies and extracts the cataractous material. So it's suctioning here and takes out all of this material. And then you can put an intraocular lens, which is an artificial lens. It could be one piece, foldable, or 3 pieces separate. And then it's foldable, put it through the same area. And then this is kind of opening in the clean posterior capsule. So that's what happens in cataract surgery. Now, when you can see here how it looks in this eye enucleated for other reasons, you can see how the one piece intraocular lens is positioned from the back in this area. The capsule, you can reach all the equatorial areas of the lens when you do the cataract surgery. So you can have, many times you have secondary cataract. This is another tumor, melanoma, but see, you have the intraocular lens here, and then you can have secondary cataract here produced by the remainder of the epithelial cells in the capsule. So in conclusion, for all this talk, for uveal melanoma, size, location, type of cellularity, and molecular profile are the leading features for prognosis. In retinoblastoma, adequate handling of the eye allows the evaluation of high-risk features for recurrence, so more than 3 millimeters choroidal invasion and or plony, post-laminar optic nerve invasion, and extraocular extension are the worst for prognosis, and of course, retrieval of the tumor for genetics. And the lens pathology is congenital or acquired degenerations, and most common is the cataract on these pathologies. Thank you very much, and I'm open for questions.
Okay, thank you, Dr. Chevez-Barrios. At this time, we'll move into Q&A. You may submit your questions via the chat box or unmute to ask a question. When submitting a question via the chat box, please ensure the message is to everyone so that presenters and attendees are able to see the question. To unmute, select the microphone in the lower left corner. Once you ask your question, please remute to avoid background noise. Okay, so let's see if we have anybody have any questions?
I have a question.
Yes.
This is Michelle Felicella from UTMB in Galveston, Texas. Thank you for such an excellent talk. I was just wondering if you could tell us about the specific molecular testing that you do on uveal melanomas.
So in our practice, we submitted for the commercial gene expression profiling test, where they use 12 different genes, and it's proprietary testing or whatever. So what we do is we send it there, and they do the gene expression profiling there. We don't do any uveal melanoma testing here in-house. But I know that other people that do not use the gene expression profiling, then and the place that everyone sends it, I mean, it's not commercial and not supporting this just because I'm answering your question, is the Castle Biosciences Laboratories is what many people send this for the these 3 types of grouping for prognosis. If you are going to do it, there are other people that do the BAP1, the chromosome 6, 8, and chromosome 3. And, you know, you look for mutations on those chromosomes and do the algorithm. People do it differently.
Thank you.
You're welcome.
Okay. Do we have any other questions?
And of course, PRAME. Everyone is doing PRAME now.
Okay, we have a question. Oops, hang on a moment. From Catherine Scherpeltz. It says, I've seen some flat choroidal melanomas with extensive uvea, ciliary body, and iris involvement, but without a single main mass. Do you have advice on how to identify where the tumor originates?
Yes, so sometimes like the one that I show you in these pictures, it's like going all the way. Most likely is from the choroid and went down, or if the main area, if you have iris invasion too and everything, it may be from the ciliary body. At that point, it doesn't matter because the base of the lesion, which is the leading size, is what is going to give you the prognosis. But depending where is most of the tumor, since more commonly comes from the choroid, it may be the mid-choroid and then invaded the ciliary body and on into the iris.
Did that answer the question?
Here, it's in the chat, there's 2 questions.
Yeah, there's one here from M. Adelita Vizcaino. It says, thank you for your excellent talk, Dr. Chavez. Do you have experience with PRAME immunohistochemistry as surrogate for molecular testing in uveal melanoma?
We don't have experience. We are now getting that in place here. We are trying to validate this right now. But since we do everything molecularly, send all of these tissues there, they do the PRAME mutation immediately. So it's in the same package. So we don't have the need actually. But for consultations and everything, now we are doing the PRAME. Right now, I don't have any experience myself, but I know it is helpful. But you have to have very good validation of your immuno.
Okay, the next question is from Jonathan Hay. It says, is PRAME helpful to distinguish melanoma from melanocytoma?
Well, yes, it is, but in my experience, the cytology, the morphology of the cells is the most helpful of everything. You have to bleach it and look for the shape of the cells. In melanocytoma, it's going to be hexagonal, round, smaller nucleus, really round, very inconspicuous nucleoli, nothing like the melanoma that has this dense cytoplasm, different shapes. I mean, it is cytologically is very different. And PRAME, yeah, I mean, it should not be positive in melanocytoma.
All right. Any other questions?
There's another, I think it was another. Okay, so how many level sections do you evaluate for each block in retinoblastoma? So the way we start is within the PO section, we ask the tech to just give us the early, what we call the early sections. Don't go to the optic nerve yet. Whatever is down on the block, we ask them to do 15 sections. We stain 1, 5, 10, and 15 with H&E and keep the other ones. And then we ask them to go to the real PO section. So look for the center of the optic nerve. And so we start with the optic nerve, and again, 1, 5, 10, and 15. And then if we are there, we stop there. But if we are not there, we go again another 10 more and so on until we get the complete section. And we save everything in between just in case we have to go back and evaluate. And from the calots, we only do 1, 5, and 10. And if we need more, we go more. And we always throw a PAS stain in number 6 because it's very helpful for membranes, for invasion into the choroid and all that.
Okay. Well,
Did we have any other questions that anyone had?
don't see any. This is
All right, thank
It's
you,
okay.
Dr. Chavez-Barrios.
You're
Thank you again
welcome.
for joining today's AANP Teaching Rounds presentation. We would ask that you take a few minutes to complete a short evaluation. Completion helps ensure accurate reporting to the accreditation board. A link to the evaluation will appear on your Path LMS screen upon the conclusion of the Zoom meeting, or you can navigate back to the main course and select the evaluation option. Once you have completed the evaluation and selected your credit amount, please then select the appropriate certificate based on your credentials. The recording will be posted to the AANP website in the next week, and thank you again to Dr. Chevez-Barrios for an excellent presentation. This concludes the session for today.
Thank you, everyone, for watching and learning.